Hello, I'm Bradley Lamm. I'm from Sinai Hospital, the Rubin Institute for Advanced Orthopedics. Today we're going to be discussing the topic of midfoot Charcot deformity, both conservative and surgical management of midfoot Charcot. So first off, most importantly, midfoot Charcot is a condition which affects a lot of neuropathic patients, and there are important elements to the Charcot foot that have to be identified. One is the stage of the Charcot. The Eichholz staging system can be utilized for this, and what location of the Charcot is also important, meaning the level or joint or bones involved. If you know the stage, you know the location of the Charcot deformity, then that basically equals what type of Charcot condition is going to present. And usually the stage and the location leads to deformity, and this deformity and Charcot can appear as changed foot architecture, bony prominences, bone disintegration, loss of the bony and soft tissue alignment, loss of stability of the foot, and eventually leads to ulceration or even further yet, infections and osteomyelitis and so forth. The problem then ensues. The foot becomes very difficult to put in a shoe, to brace, offload, or even to surgically fix. So this is the dilemma we're faced with. Understanding midfoot Charcot is very important. Putting the stage and location together typically gives you these deformities through the midfoot, and they have to be identified as medial column deformities through the midfoot, where the medial column is collapsed, or if it's even more significant than the medial column collapse is the lateral column collapse. So in the literature, there's two studies that discuss this lateral column collapse of the foot as being very difficult to correct, and it leads to collapse of the foot or a rock and bottom foot. The medial column ulcers, although are problematic, do lend themselves well to exostectomies, surgical stabilization, and typically are more easily correctable. The lateral column ulcers, lateral column deformity is difficult, and you lose stability of the foot, and you end up like what's shown here, where you have the rocker bottom foot deformity present. Why do we get these midfoot deformities? Well, if you look at the ground reaction force vector during gait, you can see that it passes through the lateral aspect of the ankle and anterior to the lateral process of the talus into the just proximal to the CC joint. And if we look at our Charcot foot deformity patterns, whether it's Liz Frank through the midfoot region or through the talonavicular calcaneocuboid region, these midfoot Charcot regions are all affected by this ground reaction force vector. And when you look at these lateral column ulcers, this is exactly where the ground reaction force vector falls in normal gait cycle. So therefore, because of the extra forces or load during weight bearing through this part of the foot and loss of stability due to the Charcot through the midfoot, you get these lateral column ulcers. So most commonly, the more proximal midfoot deformities lead to this rocker bottom foot and lateral column ulcers, whereas the more distal midfoot Charcot deformities lead to more medial column ulcers and ones that are more easily treated. These lateral column ulcers and rocker bottom feet lead to larger reconstructive procedures in order to stabilize that lateral column and recreate the foot position to a plantar foot instead of a rocker bottom foot. So what are the goals of surgical correction of a midfoot Charcot? Well, to restore alignment, restore stability of the foot, prevent ulceration and amputation, preserve the foot for proper shoe wear and bracing, prepare them for that in the future, and to allow them to be community ambulators to go about their daily lives and without incident. What are the indications for reconstruction of a Charcot midfoot? I think it's clear that instability of a Charcot joint will likely lead to some sort of ulceration or problem for the patient, and therefore an unstable foot typically needs to be surgically corrected. Also, if you have chronic ulceration that's not being healed with typical wound therapy, this also warrants a surgical correction, as this could get deeper and more extensive if left for a longer period of time. And infection, of course, and osteomyelitis has to be eradicated and require surgical intervention. The last, which is what I call the crystal ball, which is sometimes difficult to identify whether or not to surgically intervene, is when you have some malalignment or deformity of the foot, but there's no ulceration currently. But there is potential, or you feel as the treating doctor, that the patient has a potential to develop down the road because of the malalignment, ulcerations, or difficulties with their foot, given the neuropathy and the amount of deformity present. So that is kind of the questionable indication, and one that you have to discuss long and hard with, have long, hard discussion with the patients as to whether to intervene and at what point to intervene. One principle very important with Charcot reconstruction, or any type of reconstruction, is you want to obtain the correction, realign the foot or the Charcot joint or bones, either via acute correction or gradual correction. And then you want to maintain that with either fusion, stabilization, or so forth. And then most all neuropathic Charcot foot deformities through the midfoot most require a tendon Achilles lengthening of some sort, whether you're doing a gastroc soleus recession or a tendon Achilles lengthening. This is important. So you have to know normal alignment of the foot in the AP plane, axial, and sagittal plane to be able to then realign your Charcot foot deformity into a normal position. So let's take example of imaging. Just a non-weight-bearing film is not sufficient in order to plan what is required for surgery. You have to have a weight-bearing film. And even if an ulceration is present, a weight-bearing film is very important. You can get it simulated weight-bearing, not a full weight-bearing image. And here you see that although the foot is planar grade, it is showing that the midfoot is collapsed and there's a rocker bottom, a prominent cuboid bone. The calcaneus is not inclinated as it should be. It's parallel to the planar aspect of the foot. And here you see also further standing x-rays as an example of not only a subtalar Charcot, but also a mid-tarsal joint Charcot deformity here. And again, also important to observe or image adjacent joints to ascertain whether or not there's further Charcot or other adjacent joint Charcot deformity. Here's an example of a subtalar joint Charcot where the heel is in varus, and this can be obtained via long leg calcaneal axial view, as you see here on the left, and on the right screen you see the hindfoot alignment view, which also gives you a good axial image of the calcaneus and its relationship to the tibia. The surgical approaches, I feel that the best correction is typically achieved with multiple joint fusion. That although you have one joint that is Charcot or one level of Charcot, it's important to perform multiple joint fusions and formal fusions. As far as rigid fixation, I think that's essential. for any surgical fusion or reconstruction, but more essential than the typical patient in the neuropathic patient. Let's take this case, for example, case 1. This is a 50-year-old male with diabetes mellitus with neuropathy. There's a Charcot of the tailor-navicular joint. You see dislocation at the image on the top. And on the bottom, you see reconstruction with a locking plate across this TN joint fusion site with realignment. However, with just this one joint fixation, you can see that immediate post-op, nice position. However, 3 months post-operatively on the bottom, you can see broken hardware and collapse of the TN joint. Therefore, failure of hardware, failure of fusion, and recreation of deformity. Let's take a second example. Here's case 2, a 53-year-old female with diabetes mellitus with neuropathy, Charcot of the Lisfranc joint. This is the lateral view showing the Lisfranc Charcot condition. And here you see after plating, medial column plating, this is 2 years post-operatively, not only fusion of the navicular cuneiform, but also the cuneiform first metatarsal. This plate did break, even though it's a locking plate, due to some settling and shifting of the bones, and that although we did multiple joint fusion here, stable internal fixation was not achieved. How about case 3? This is a 59-year-old female, diabetes mellitus with neuropathy, Charcot of the Lisfranc, and you can see here there's some lateral deviation of the forefoot on the tarsal region, as well as some sagittal plane fault. So this was fused with some internal pin fixation along with locking screw and plate fixation. You can see nice restoration of the alignment of the Meares angle postoperatively. A temporary extra-articular ankle arthrodesis pin was placed for stability of the ankle correction after gastrocsoleus recession. The patient 20 weeks later, postoperatively, you can see here that the arch has recollapsed through this Charcot joint. The fixation has failed. The union has not been fully, not a full union is seen, and further breakdown of more proximal deformity through the tailor-navicular joint is now seen 7 months postoperatively. Revision for this treatment, for this previous treatment, was done with internal intermedullary metatarsal screws and bone grafting and so forth to realign this foot. So this was the previous patient who had this collapse of the foot, was taken back to surgery, bone grafted, and realigned with this internal fixation method of intramedullary metatarsal fixation. You can see here nice restoration of the alignment of Meares angle on the lateral view post-revision. So you can see that rigid internal fixation is important and formal fusion is very important, and I think it also is evident that multiple joint fixation is important due to adjacent joint collapse as seen in the previous examples. So what are the surgical approaches to the midfoot Charcot? I think that there are 3 general approaches that one could take to correct these Charcot foot deformities when surgically indicated. 1 is acute correction, 2 is acute correction with the addition of external fixation, and the 3rd is gradual correction with external fixation, a 2-stage method. I'm going to go through examples of each 3 of these surgical approaches. So let's take an example of Eichenholz stage 3. The location is the cuneiform Lisfranc Charcot region, and I achieved this via acute correction. So here's an example of a middle-aged male with this Lisfranc Charcot with, you can see, previous surgery for amputation of the 5th ray due to the Charcot condition, neuropathic Charcot condition. Here you see the collapse on the lateral plane. So here's intraoperatively loading with a footboard to assess the equinus. You can see before on the left and after the gastrocsoleus recession, in this case to lengthen the Achilles tendon. Whatever is required as far as your posterior muscle group lengthening to achieve a dorsiflexion above neutral with the knee extended during the intraoperative course is optimal. Here, this is this extra-articular ankle arthrodesis pin, which is temporary to hold the position of your corrected equinus after equinus correction to maintain the heel in the appropriate position. This does not invade any joints and therefore is ideal to maintain position. Here you can see the AP version of that pin, which stays lateral to the posterior neurovascular bundle. After correction of the hind foot, then the midfoot is evaluated, and medial approach was obtained for this patient, and then curettage and typical AO principles of formal joint fusion is then approached. A retrograde pin is placed through the medial column, and then integrated across the Lisfranc joint into the first metatarsal to then allow for correction of the Meares angle. This site was then bone grafted, fenestrated, etc., along with the adjacent joints proximally, the cuneiform navicular talar region, and large diameter cannulated screw insertion for restoration of the alignment, this intermedullary metatarsal fixation. Additional fixation is placed in the lateral column and the medial column for further stabilization. The CC joint was also arthrodesed to achieve a rigid mid-tarsal joint. Here's the before and after of this acute correction through the medial column. And here's also the before and after acute correction of the foot, weight-bearing postoperatively, nice consolidation with these formal fusions as mentioned. How about this example? This is stage 2 Eichenholz. This is a navicular Charcot, again a midfoot Charcot, but this is a not just acute correction, but we're adding external fixation for additional stability. So here's an example of the navicular Charcot. You see the collapse of the navicular on the talus, the shortening of the medial column. You see the sagittal plane deformity as well, the faults through the navicular region. And this foot was also unstable. The root etiology of this navicular Charcot was likely the varus of the hindfoot correcting the varus of the hindfoot through compensation created extreme valgus of the forefoot, therefore creating this navicular Charcot likely, and therefore was addressed as well, the hindfoot varus, along with the navicular Charcot for maintenance of the deformity correction and for this deformity not to reoccur. Therefore, the heel varus was achieved, correction was achieved via a Dwyer calcaneal osteotomy. This was also laterally translated in order to obtain a central heel position underneath the long axis or anatomical axis of the tibia. So you can see the lateral translation of the calcaneus and fixation there. You can also see the navicular region through a medial incision was opened and the talar navicular joint was fused with bone graft and intermedullary metatarsal screw fixation, along with fusion of the cuneiform navicular joint as well. You can see the Lisfranc joint was not formally fused in this case. Lateral column screws were also inserted through the a lateral column screw is also inserted through the fourth metatarsal and through the calcaneocuboid joint, which was also arthrodesed, and through the and a third screw through the central column of the second metatarsal into the calcaneus. Not only was acute correction with formal fusion bone grafting achieved with intramedullary screw fixation through the metatarsals into the hindfoot, but also an external fixation device was applied for further stability during the postoperative healing course. Here you can see placement of the external fixation device. There's two oblique wires placed through the calcaneus, a medial lateral wire, a oblique wire through the posterior medial, and anterolateral calcaneus. These oblique wires allow for good fixation of the calcaneus. Here you can see the oblique calcaneal wire in this direction, and the medial lateral calcaneal wire in this direction. The wires are placed such that they are not interfering with the intramedullary screw fixation and are allowing for stability along with forefoot stability, as you see here. The screw sites for entrance is beneath the metatarsals, as seen here, 1, 2, and 3. Those were the sites of the screw fixation in his foot here. The external fixation device is applied a tibial ring block, as shown here, along with a foot frame, as shown here. The foot frame is completed to increase stability of the entire construct, and multiple midfoot wires are placed, as well as tailor wires. Tibial half pins is shown here, along with tibial smooth wire fixation shown here to create stability of this foot. The X-ray image shows that the external and internal fixation are placed together. This is maintained for approximately 3 months while fusion is taking place within the midfoot. The external fixation allows weight bearing during the postoperative course and also allows for adjustability if necessary for further compression across the midfoot if needed. The fixator is removed and the internal fixation is maintained. You can see here the fusion of the midfoot is obtained as shown, and the lateral radiograph shows the consolidation along the medial column from the formal fusion. The calcaneal osteotomy is healed as well. You can see the dorsal translation of the calcaneus was performed to allow for to allow for lengthening of the posterior muscle group without open tendon surgery. Here's the postoperative realignment of the calcaneus. You can see the calcaneus and the central aspect of the calcaneus is beneath the talus and realigned as you remember the previous varus picture of the hindfoot alignment view on the left. Here's postoperatively a patient standing. You can see the previous medial incision and the multiple pin fixation sites of the leg, on the leg. How about another example where the third example, where I performed a gradual correction with external fixation, the two-stage method. This was Eichenholz stage 2 Midfoot Charcot. Here's an illustration of what this typically appears like, where you have a plantar ulceration, midfoot rocker bottom, the cuboids usually in this region where it becomes prominent. You have equinus deformity and a forefoot that subluxes dorsally and typically in varus. The first part of this procedure is to do a tendon Achilles lengthening to increase the heel pitch as seen here. The second step is to apply an external fixator for gradual correction of the forefoot on a rigid fixed hindfoot and tibia. Therefore, the tibia, calcaneus, and talus are fixed in a neutral position, and the gradual correction occurs to the midfoot by lengthening the forefoot and plantar flexing the forefoot in this case to realign the foot as shown here. The forefoot is realigned, and then the normal anatomy is restored by this distraction, realignment, and then formal fusion can occur with ease, and the external fixation can be removed or maintained for compression, or the external fixation can be removed with internal fixation placed and a cast applied. This gradual correction can take anywhere from 2 weeks to 4 weeks for gradual correction, and then you have the decision whether you want to maintain the external fixation device to create further compression across your formal fusion, or you can remove the external fixation and apply internal fixation as shown here, medial lateral column fixation as well as central column fixation as mentioned before, or whatever fixation method you choose. This is an example of gradual correction through the midfoot. This is an example of a totally subluxed navicular outside of the cuneiforms, medially displaced. You can see also planarly displaced with the forefoot subluxed and dislocated, subluxed significantly dorsally, period. You can see the break in the Meares angle as well. Here's the hindfoot alignment view showing valgus of the heel of 12 degrees in addition to the forefoot deformity. Here's the clinical appearance of the foot with the medial column collapse. So first, what was applied is an external fixation device to create gradual correction. You can see the separation of the navicular from the cuneiforms here, and also the CC joint being distracted on the hindfoot. Again, the hindfoot and ankle and tibia, fibula are all fixed, and the forefoot is distracted on that fixed hindfoot. You can see that here as well. The forefoot is distracted on the fixed hindfoot. This can be done with Elizaroff rods or other fixation devices to basically distract the forefoot on the hindfoot to allow for this, for bony relocation. The concept is basically traction. If you have a fracture, as you do in trauma, you apply traction. Traction allows for reduction of bony fragments, and therefore you can fix it. So again, you obtain the correction via distraction in this case, and then you maintain it as we remove the external fixation. We have a supple foot to then realign after the 2 to 4 weeks, and we go and surgically open the foot via small open incisions at the level of the joints that are Charcot, realign those joints slightly further to ensure anatomic alignment, create formal fusions, and then we place our fixation, in this case intramedullary metatarsal fixation as well. You can see the realignment of the medial and lateral columns, fusion throughout the entire midfoot after formal fusion, open and formal fusion, and the fixator was removed after placement of these internal fixation method. So therefore, in this particular patient, the fixator was on approximately 2 weeks to gain that distraction realignment. The fixator was then removed. Formal fusion was performed with internal fixation. Patient was placed in the cast for 2 months after the fixator was removed, and therefore, in approximately 2.5 to 3 months, the patient was weight-bearing in a cam walker boot and consolidated fully. The patients are typically braced for quite some time, 6 months to a year after the operation, to ensure full consolidation of the formal fusion sites. Again, you can see the before and after on this image, and you can see the realignment of the 12 degrees of varus, or I'm sorry, 12 degrees of valgus that we had prior to a neutral heel on this hindfoot alignment view postoperatively. Here she is standing postoperatively. The left foot is the foot that was fixed. You can see the previous incision medially here. You can see the rectus heel position. Again, you can see the medial heel, or medial arch incision well healed with restoration of the arch. Stance in her shoes. Here's another example of a 54-year-old male with diabetes and neuropathy. He had a Charcot through the calcaneus and the subtalar joint region, and he's presented with a plantar ulcer, but posterior central in the heel bone. He therefore had a calcaneal gait. You can see the collapse of the subtalar joint, the fracture and Charcot through the calcaneus here, and the decrease in the heel height, which is producing impingement of the anterior talus against the tibia. And he develops, as you see here through the x-ray, an ulcer plantar central heel due to this calcaneal deformity of a heel Charcot. Here are his other images as well to fully assess him during weight bearing and to identify any other underlying deformities present. A CAT scan was obtained to identify the level of the Charcot, the extent into the subtalar joint, and the non-union that's present due to the Charcot. Therefore, we plan to debride the heel and apply external fixation for gradual correction of this deformity. Here you can see olive wires placed to hold the calcaneus and pull plantarly to restore the heel height. Here you see external fixation application with thread rods placed posteriorly to allow for posterior distraction of the heel. On the left, you can see limited space between the posterior tuber of the calcaneus and the subsentaculum and talus, versus on the right, you can see excellent distraction of this posterior talus and posterior tuber of the calcaneus, whereas we're creating space where bone used to be due to the previous Charcot. So this gradual correction took place over approximately 3 weeks to obtain a adequate heel tuber position. Once this was achieved, as you see here, we had a non-union of the calcaneus plantarly and a void of previous calcaneal bone that, due to the Charcot event, had dissolved. So then, after obtaining the position, now we have to maintain the position. We remove the external fixation, we put a bone block into the site, and we implanted internal bone stimulator for further healing, and also achieved union of the non-union plantarly. So this screw fixation creates stability and compression across the non-union site. Here you see a fresh frozen femoral head placed in the void, which was achieved by distraction and lengthening with the external fixation device, screw fixation, bone grafting, and internal bone stimulator placed to allow for full reconstruction, full realignment, and bone block orthodesis of the subtalar joint was achieved. The heel was verticalized on the height alignment view, as you see here on the right. And 5 years postoperatively, although there is some minor collapse of the graft, the position is still restored, and excellent alignment is noted in this gradual two-stage method of gradual correction of the Charcot with then formal fusion. So in conclusion, Charcot reconstruction of the midfoot is very difficult and should include eradication of any infection, ulceration, and osteomyelitis, and also should achieve multiple joint fusions with formal fusions of all joints. Should typically increase, double the follow-up and double the fixation, as these are very difficult patients to heal and to treat. due to their multiple factors, and that this intramedullary screw fixation, which I showed throughout the presentation, has been, although it's been very good, it's not the answer to all problems, as you see in this example. So again, remember your principles regarding the things that we discussed in this lecture, and I thank you for your time and attention.